Daratumumab as a single agent is a safe drug to use. The issues that one has to be aware of is, number one, the drug can interfere with red blood cell cross-typing. Therefore, you have to remember to send to your local blood transfusion lab a sample before the patient starts daratumumab so that appropriate cross-matching could be made. Secondly, this drug is, like most monoclonal antibodies, sometimes associated with a first infusion reaction. I emphasize first in that most of the time it is the only time that these reactions occur, and they generally are not seen in later rounds. The infusion reaction is similar to that seen with other monoclonal antibodies, but in this case is particularly focused on upper respiratory tract allergic type symptoms: runny eyes, runny nose, tightening of the throat, and in severe cases wheezing and even some stridor. This can be managed by pre-medicating the patients appropriately as according to the label, and the use slowing down the infusion and reintroducing anti-allergy drugs as part of the management of side effects should they occur. These events occur in up to 40% of patients, but they are generally mild and fairly easy to manage. Because, however, that this reaction can happen in the first dosing, one of the disadvantages of daratumumab is that it does take a long time to do the first day infusion, up to 8 hours in some cases, which means it puts a stress to some degree on treatment centers that open late or close early. That we hope will be resolved in the near future with the introduction of subcutaneous daratumumab, but that is some time away still at this time. Beyond the first 2 or 3 cycles, many academic centers particularly have now moved the infusion time down to 90 minutes, so the first day can be long, week 2 and perhaps week 3, 5 or 6 hours, but thereafter a 90-minute infusion can be safely employed if the subject that's been treated has not seen any evidence of infusion-related reaction. The final side effect I think people need to be aware of is that this is a very powerful drug at killing myeloma, but also at attacking normal plasma cells. Therefore, immune suppression is an issue. Infection rates do increase with the use of daratumumab in combination in many of the trials that we've looked at the addition of this agent to conventional therapies. And the physicians just need to be aware of that, to be thoughtful about how they prophylax, to make sure vaccinations are in place. Perhaps growing evidence that the use of a quinolone antibiotic in the first few months of treatment is advisable. My personal experience of using daratumumab has been very positive. I think the concerns that people had about infusion reactions in the very early days of introduction of this drug have generally abated. And like many monoclonal antibodies we use in oncology, it is quite easy to use, and once the infusion staff get used to the drug, I don't foresee common or significant problems for the vast majority of patients. I do want to emphasize the need to be vigilant about infection, to make sure your patients are on acyclovir to prevent shingles and that their flu vaccine and other vaccines are up to date. Remember to tell your nurses to send the blood transfusion compatibility testing before starting the drug. The use of daratumumab, lenalidomide, dexamethasone is appropriate for a large swath of the patients we see, particularly the transplant-ineligible patients. I think areas in which one might want to consider use of a proteasome inhibitor might be patients with very high-risk disease, where there is evidence that a proteasome inhibitor can be quite useful. And secondly, in patients with renal failure, where the use of lenalidomide may not be appropriate. Or in patients who can't access lenalidomide because of financial toxicity, because of inability to obtain through insurance, or perhaps because even after 1 or 2 doses they develop rash or intolerance of that drug. In all of those circumstances, I think a proteasome inhibitor should be preferred. And when a proteasome inhibitor is going to be used, the regimen that has been approved by the FDA that incorporates daratumumab is Velcade, melphalan, prednisone, and daratumumab. So the combination of those 4 drugs would be the recommended treatment for somebody who cannot tolerate or cannot access Revlimid.